Hello, Nephew community. Thank you for joining us for today's webinar, The Role of the Pharmacist in the Neurocritical Care Unit. I'm Dr. Hannah Lambert, Clinical and Scientific Liaison with Otsuka Pharmaceutical Development and Commercialization, Inc., and I'm very excited to be here with our speaker, who I'll introduce here in just a moment. If you have any questions, please feel free to type them in the chat box and we can try to address them at future presentations. Today's webinar is sponsored by Otsuka Pharmaceutical Development and Commercialization, Inc., and speakers are paid consultants for Otsuka. The information provided is intended for your educational benefit only. No CME credits are offered. It is not intended as, nor is it a substitute for medical care or advice or professional diagnosis. Users seeking medical advice should consult with their physician or other healthcare professional. While conducting the discussion, our speakers aim to provide you with information that is accurate, not misleading, scientifically rigorous, and does not promote Otsuka products. It is my pleasure to introduce and be here today with Dr. Denise Rhoney, PharmD. Dr. Rhoney is a professor within the Division of Practice Advancement and Clinical Education at the University of North Carolina, Shellman School of Pharmacy in Chapel Hill, North Carolina. Dr. Rhoney received her doctorate degree at the University of Kentucky College of Pharmacy in Lexington. She completed 2 years of pharmacy residencies specializing in critical care at Albert B. Chandler Medical Center at the University of Kentucky and completed a clinical research fellowship at UNC Chapel Hill, Glasgow. Dr. Rhoney is a fellow of the American College of Critical Care Medicine, American College of Clinical Pharmacy, and the Neurocritical Care Society. Dr. Rhoney has been an investigator on numerous clinical trials, many as principal investigator, and her research is focused mainly on traumatic brain injury and acute stroke. She has expertise in cerebral spinal fluid pharmacokinetics of pharmacologic agents. Her current focus is using this strong clinical background and research dedication and translating this to the interface between practice and education. So, Dr. Rhoney, as a neurocritical care pharmacist, can you describe your role in this setting?
Absolutely. I think my role as a pharmacist in the ICU is not much different than any pharmacist role where we use this pharmacist patient care process. I think our role is really in identifying, preventing, and managing any medication therapy problems that arise in the ICU population. In the ICU, we're really concerned about the complexity of the patients that we see in the ICU. They have multiple diseases, multiple organ dysfunctions, polypharmacy, and they're a very vulnerable population to medication therapy problems. So a pharmacist really is a critical part of the ICU team in order to prevent any medication morbidity. We take a closer look at this pharmacist patient care process, and we'll walk through and kind of apply it to what we would think about in patients that exhibit hyponatremia. We start first with the collect phase. It's really essential that we collect key information relevant to hyponatremia. Now, this is not going to be an all-inclusive conversation of that, but some key factors that we're looking for obviously include serum sodium, but also things such as serum osmolality, the volume status of the patient, renal function of the patient, serum glucose, any markers of hypo or hyperthyroidism, and also key drugs. And there are a lot of drugs that can cause hyponatremia or exacerbate the condition. So as pharmacists, this is really important for us to look at. But also critical is to look at the symptoms they're exhibiting, the type of symptoms, and the onset of symptoms to figure out if this is an acute or chronic process. We then use all that data in the assess phase to try to think about what is the likely etiology. And as pharmacists, we're not diagnosing disease, but we are trying to diagnose any potential drug-induced causes and trying to, again, prevent and manage any medication therapy problems. We then develop a plan and implement a plan that focuses on what the cause is, the underlying etiology, and then obviously we want to follow up with frequent monitoring of serum sodium and looking at any symptom resolutions and also monitoring for complications to aggressively control the serum sodium. So to me, a pharmacist's role really is at the center of identifying, preventing, and managing medication therapy problems.
The pharmacists are certainly an integral part of the care team in the ICU, and we know that hyponatremia sometimes occurs in these patients. How often do you encounter hyponatremia, and what is your role in managing these patients?
Sure. I think first we should start with defining what is hyponatremia. Hyponatremia is commonly defined as a serum sodium less than 135 milliequivalents per liter. But this cutoff often varies, and it varies if you look at the different severity levels of hyponatremia. We typically can subdivide the severity levels between mild, moderate, and severe, with mild being 130 to 135, moderate 125 to 130, and severe less than 120. The neurological effects of low plasma sodium are really related to the severity and also the rate at which the sodium falls. So while we traditionally will say serum sodiums between 125 and 130 are considered to be moderate, in patients that have brain injury, they're extremely vulnerable to these neurologic side effects. And for that reason, we typically use the definition of less than 130 to be clinically significant and classified as severe in the neurocritical care population. It is a very important electrolyte disturbance that we see, and we can see it in up to 50% of the patients in the neuro ICU. It just depends on the definition used, and every study uses a different definition. So that's why this incidence is variable. But we do know it is associated with significant morbidity and mortality. Given that we established that hyponatremia is a really important electrolyte disturbance in the neurocritical care unit, I want to talk about two pathologies a little more closely, and these are the populations that we will see hyponatremia somewhat more commonly. If we look first at subarachnoid hemorrhage, subarachnoid hemorrhage has been reported in about hyponatremia in these patients, about 30 to 56% of the patients. It typically develops the first 7 days, and it really depends on the location of the aneurysm, with some location of aneurysms more associated with hyponatremia than others. Also, in patients that develop vasospasm, you can see an increased incidence also of hyponatremia. And also, we give these patients a large amount of volume if they do develop vasospasm. So they are exquisitely sensitive to the development of hyponatremia. The next population is the traumatic brain injury population. This is the most common endocrine complication that we see in these patients. It develops usually the first week. About 54% develop it the first 2 days, although 8% will develop hyponatremia long term, and we'll see it as they go and transition to rehab setting. And this is really important because they're already at risk for cognitive decline if they do develop hyponatremia. So it's real important to be aware of the different populations of patients in the neuro ICU that we typically can see a hyponatremia, and as pharmacists, really be on top of monitoring and making sure that we're very proactive in identifying hyponatremia in these patients, given the consequences that can occur if they do develop it.
So now that we know hyponatremia can occur in over 50% of patients in the neurocritical care unit, can you share with us some of the risk factors for hyponatremia in these neurocritical care patients?
Yeah, so we talked a little bit about the different pathologies of neurocritical care patients that are associated with hyponatremia, but there are other factors that we can see in general ICU patients or general patients that also place these patients at risk. If we look at some selected conditions, we can see conditions such as heart failure, cirrhosis, extremes in ages, the development of hypothyroidism, renal dysfunction, adrenal insufficiency. These are all risk factors that can occur in these patients and would place these patients at increased risk of hyponatremia on top of their underlying neurologic pathology that occurs. But more importantly, I think as pharmacists, for us to think about are the select drug classes that we really have to be familiar with and be proactive in monitoring for, because these agents can place these patients at risk for development of hyponatremia. They include classes of drugs, including the diuretics, opiates, NSAIDs, some of our anti-epileptic agents, antidepressants, antipsychotics, and anti-diabetic agents, and some antihypertensive agents. So it really is important to be aware of the various risk factors that are there and for us to monitor for it and proactively make the team aware if we do think we're experiencing particularly a drug-induced cause.
So why is it important to identify hyponatremia in this patient population, and what are some of the consequences?
One thing you'll see with hyponatremia, there can be a wide and variable range of consequences that it can occur. And it depends on a couple of factors. And it depends on the acuteness of onset of the hyponatremia. And if we look at first patients that develop acute hyponatremia, which is what I more likely see in the neuro ICU, these are patients that develop hyponatremia in less than 48 hours. They'll present with very serious symptoms like cerebral edema, seizures, and coma. Morbidity and mortality is extremely high in these patients. And so we have to address their hyponatremia very quickly and rapidly try to correct the sodium imbalance. We also know that patients that develop hyponatremia in the ICU have increased lengths of stay, an increased risk of readmission to the ICU, and as I said before, increased mortality. On the other hand, if you look at patients that develop chronic hyponatremia, they may actually often be classified as asymptomatic because their symptoms are very nonspecific. They have things like such as nausea, vomiting, confusion, some gait disturbance that can lead to falls and fractures, but overall not atypical for signs and symptoms you might see in any patient. So it may go unrecognized that they actually have hyponatremia. But even though they have, we would say, milder symptoms or sometimes asymptomatic symptoms, we still have to be very careful of correcting sodium, particularly in these patients, because if we correct their sodium too quickly, they run the risk of developing something known as osmotic demyelination syndrome.